Hi, I'm Rhiannon Morgan. I am an equine radiologist at the Royal Veterinary College in Hertfordshire. Today I'll be talking about one of the most important developmental orthopaedic diseases in young athletic horses, osteochondrosis. So the term that really defines the core of osteochondrosis and why it occurs is failure of endochondral ossification. I'll return to this term more within the next few slides. And we'll discuss more the recent advances in our understanding of this disease process. Otherwise, I'm going to cover where it occurs, what it does within the joint, what we can do about it. I'm sure you're all very familiar with this developmental disease, so I'll try to combine some of the more current advances in this area. So this orthopaedic disease occurs in young, large breed horses, and it can cause a variety of clinical signs. The age at which the disease manifests clinically or starts to cause clinical signs can vary from a young foal to horses over 10 years old. So lesions can remain silent and they can only cause clinical signs, or they can cause clinical signs later on in life. But those lesions must have been there since they were a foal. No new lesions can occur once the yearlings reach skeletal maturity. The disease often starts to cause problems when the horse is put into training, when they're athletically challenged. And this age will obviously differ with different populations, being earlier in the thoroughbred racehorse than warm bloods destined for dressage. And often the horse can be sound, or it can experience a variety of different degrees of lameness. It can present with a fusion of the joint, as you can see in this picture, outlined by the red arrows with the Femropacellar Joint effusion. The disease can affect more than one joint in over 50% of cases. It usually occurs in the same joint on the contralateral limb, but it can also affect multiple joints in the same horse as well. So the most common way to diagnose osteochondrosis is through radiography, but ultrasound can also be a useful tool, which we'll talk about later. Lesions are found at very specific predilection sites in each joint. This is due to certain biomechanical forces that affect certain joints and the blood supply found in that region, among some other factors. The degree of severity of each lesion on X-rays, or the grade of the lesion, doesn't always mirror the clinical signs the horse is showing, and lesions can also spontaneously resolve whilst the horse is still maturing. This can occur at different times for different joints, as each joint matures at a different rate. So other factors to think about with osteochondrosis, a heritable predisposition has been documented alongside rapid growth, dietary imbalance of both macro and micronutrients, and exercise as well. And when we think about osteochondrosis, we often think about osteochondral fragments, or some would say joint mice within the joints. And these can be adjacent to the depressions we see in the bone, or they can be found elsewhere in the joint if they've travelled. The surgical removal of fragments from a joint was reportedly performed as early as 1558 by a French surgeon named Ambroise Paré, and he's generally regarded as the father of modern surgery. His work was based on his time in the battlefield, but the fragments he was removing were more likely of traumatic origin rather than developmental origin, as we see with osteochondrosis. He also reintroduced the ligature of arteries instead of cauterization for amputation, which you can see in this picture. But it was the German surgeon Franz Koenig who first documented three theories for loose fragments in the joint. First, as a consequence of severe trauma, as we mentioned on the previous slide. Secondly, due to a lesser trauma, which results in necrosis of the subchondral bone, leading to a separation of a fragment of dead bone. And thirdly, fragments which formed without evidence of trauma, but were due to some unidentified lesion, which is likely what we're talking about today, osteochondrosis. He named the disease osteochondritis dissecans, describing a subchondral inflammatory process resulting in a loose fragment. But this term, osteochondritis dissecans, has led to much confusion, and several terms, including osteochondrosis, osteochondritis, and osteochondrosis dissecans, have been used synonymously. In 1986, these terms were better defined. So osteochondrosis relates to the disorder, osteochondritis relates to the inflammatory response to it, and osteochondrosis dissecans is used if there's a separate fragment present as well. So a consensus paper was published in 2013, which has provided a useful classification system which can help describe lesions based on their functional and anatomical considerations. And this includes developmental orthopedic disorders, which covered a broad list of orthopedic disorders related to disturbances in musculoskeletal development. Whereas the term juvenile osteochondral conditions was used more for those related to immature joints or growth plates. So this includes what we're talking about today, osteochondrosis, but also includes cuboidal bone disease and other forms of the immature skeleton, such as juvenile bone cysts, osteochondral collapse, avulsionate insertion sites, and physitis. So this brings us back to why does it happen and what is endochondral ossification? So quite a complex thing to go through, and I'll try and break it down. So in all mammals, the primordial skeleton starts as a cartilaginous structure that partly transforms into bone before the horse is born, but parts of it will remain as cartilage and then continue to ossify or become bone after birth. And during this period, the bones will grow and ossify. So in this slide, you can see, an X-ray of an immature horse's stifle. So this is a slide on the left, and there's a cross-section of an anatomical specimen on the right. The bony area is in brown on the cross-sectional specimen, and you can see the outline of the bone depicted by the arrows is very irregular. And this mirrors the irregular surface on the X-rays as well, with that white arrow. But there's also this white tissue over the top of them, which is a thick layer of cartilage or growth cartilage. And you can't see this in an X-ray because it's not ossified yet. So this cartilage is going to become ossified as the horse matures, and this basically is endochondral ossification. So now we're comparing a skeletally immature horse on the left with a mature horse on the right, and you can see what the fully mature trochlear ridges of the femur end up looking like in a mature horse. They are fully ossified and they have smooth margins, and you can see that the trochlear ridges have changed from comparatively similar sizes in the immature horse to different sizes in the mature horse. The medial trochlear ridge is much bigger. They'll still have a very thin layer of articular cartilage overlying the bone, which you can't see in the X-ray. So I've added a transverse cross-section of the specimen into the middle of the slide, and that corresponds with the blue line in the X-ray on the right. And I just wanted to show a cross-section of the trochlear ridges. The lateral trochlear ridge is much smaller and sharper, or more triangular than the medial trochlear ridge, which is much rounder. And there's this thick yellow whitey substance over which is the articular cartilage and the patella resting against the cartilage. So going back to thinking about endochondral ossification, so at the ends of the bones or at the articular surfaces, this thick cartilage area, which we've been looking at so far, functions as a type of growth plate similar to the physes we see at the end of long bones, which help lengthen the bones. And from a germinating layer of cells, the chondrocytes or cartilage cells proliferate and they lay down this purple extracellular matrix, which is a scaffold of cartilage. As the chondrocytes move through towards the external aspect, they hypertrophy, they get bigger, and then they undergo apoptosis where they die. Then the bone cells, the osteoblasts, move in to start mineralizing this extracellular matrix or scaffold, and they turn the cartilage into bone. So the histology image on the left demonstrates what happens when endochondral ossification fails. So the growth cartilage, the purple substance we see here, fails to become bone because it has no nutrient supply. So we've got this concave lesion of dead cartilage, basically, and that's what will form those smooth depressions that we see in our bone surfaces with OC. So a research group in Oslo have produced a great quantity of research identifying exactly what goes wrong throughout this process to result in failure of endochondral ossification, which is a failure of the growth cartilage to become bone. So with increasing age and decreasing relative volume of the growth cartilage as it starts ossifying, the blood supply gradually regresses. And you can see the blood supply to the trochlear ridges of the femur here. These specimens have had a barium perfusion through the vessels, so you can see the vascular supply of the growth cartilage. Now, we generally think of cartilage as an avascular tissue, so it's really interesting to see the vascular supply to the growth cartilage here. So this supply in immature growth cartilage is temporary because I said articular cartilage in adults is avascular, it has no vessels. So we know that osteochondrosis is a result of the failure of endochondral ossification, and this research group has linked this to a failure to supply the growth cartilage with blood, as we were just looking at. The cartilage that house these blood vessels that the blood vessels are traveling through are filled with either cartilage or bone, which is resulting in a failure of the blood supply to a certain area of the bone. If the growth cartilage fails to have a blood supply, then there's no supply of nutrients to that area, and that will lead to ischemic necrosis and death of that cartilage. And that's, again, why we see this depression in the bone, as we can see on this micro-CT picture here. So some lesions do spontaneously regress, and this is thought to be due to a secondary repair response which can occur within the growth cartilage and the bone. But we need to do more research into this area to work out exactly why this is occurring. So why does the blood supply to this area fail? We already know that osteochondrosis occurs because the growth cartilage loses its blood supply and then doesn't get ossified. But why does the blood supply fail in these locations? So the osteochondral unit, the area of bone and the growth cartilage, is quite fragile in growing animals. It's made up of relatively weak layers of growth cartilage adjacent to the ossification front, and they're quite differently dense materials. The scaffold of extracellular matrix, where the proliferating chondrocytes were laying down extracellular matrix, this isn't very strong. And there's also a difference in orientation of the collagen fibrils in this matrix, which makes it quite susceptible to trauma or biomechanical stresses. So in essence, the osteochondral unit, or this junction, isn't very strong due to it being in quite a dynamic state. So any excessive loading on the articular surface can induce lesions at this junction. Additionally, a failure in vascular supply can also occur secondary to a septic process. So if there was a septic joint in that location, bacteria can enter the cartilage from a septic joint or via hematogenous or blood supply as well. So that can additionally cause a failure in vascular supply. So thinking about the site-specific areas, there are 4 broad anatomical areas that osteochondral lesions can arise, and these are due to the biomechanical differences in these areas. So these categories include the articular surface, the periarticular area, so around the joint margin, within the subchondral bone, which sits underneath the cartilage, or at the sites of ligaments inserting into bone. So starting with the articular surface, this results from an overload due to compression or shear forces on a sharp area. And this is commonly found at angled parts of the joint of an articular surface, such as the trochlear ridges of the femur or the sagittal ridge of the cannon bone in the fetlock joints. In the stifle, the location of maximal pressure of the patella, so when the stifle is in semi-flexion, is centered over the proximal third of the lateral trochlear ridge. And again, this is narrower than the medial trochlear ridge and a bit sharper. So you can imagine that there's a degree of maximal pressure from the patella being exerted on that lateral trochlear ridge. The lateral trochlear ridge is one of the most common sites of osteochondrosis in the horse. And the black arrow in the X-ray is pointing to a very subtle depression in the lateral trochlear ridge. Another predilection site for this type of osteochondrosis is the dorsal aspect of the sagittal ridge of the third metacarpal or metatarsal bones, or the cannon bones. And this is in the fetlock, where it articulates with the sagittal groove of P1. So the X-ray on the left shows a flexed fetlock, and you can see a small radiolucent region and a slightly flattened dorsal aspect of the sagittal ridge. When the horse is weight bearing, of course, the sagittal ridge in that location will be superimposed by P1, so you won't be able to see it there. So moving on to periarticular lesions, these occur at the periphery of joint surfaces and can be induced by compression in full flexion or extension on sharp margins. It's often found in joints with a large range of motion, like the tartar joint, at the distal intermediate ridge of the tibia, commonly known as dirt lesions. And you can see that here in this diagram with the black arrow pointing to the distal intermediate ridge of the tibia. Another predilection site for this type of osteochondral lesions is the dorsal aspect of the sagittal ridge. Sorry, one second. Another predilection site is the fetlock, and these commonly occur at the dorsal-proximal aspect of P1, the palmaro-proximal aspect of P1, and the apex of the sesamoid bones, so at each location of the joint margin in this joint. Osteochondrosis occurring in subchondral bone may result from compression, so that can include areas of collapse and subsequent lysis at locations of the articular surface that undergo maximal points of pressure. These areas are then thought to have a type of failure of endochondral ossification and are then considered part of the osteochondral process. These lesions are generally found at focally highly loaded convex articular surfaces, so like the medial femoral condyle, the distal aspect of the proximal phalanx, or the metacarpal or metatarsal condyles of the fetlock, as you can see in these diagrams. So we've got a medial femoral condyle in the X-ray and a condyle of the third metatarsal or carpal bones underneath. And these areas can go on to form subchondral bone cysts, which are often diagnosed in yearlings and 2-year-old thoroughbreds soon after they go into training. There are other processes which can cause the subchondral bone cysts. Osteochondrosis is just one pathway. And acquired subchondral bone cysts can occur in horses of all ages. Trauma of the weight-bearing surface is another hypothesized reason. So in these X-rays, we've got a large bone cyst associated with the elbow joint in the proximal aspect of the radius, one in the distal aspect of the proximal phalanx, likely associated with the proximal interphalangeal joint, and again, one in the medial femoral condyle on the left. Now, MRI can help us gain more information about how these subchondral bone cysts are communicating with the articular surfaces. And lastly, we go on to sites where ligaments insert into bone. So tensional forces at these sites on a young skeleton can be responsible for biomechanically inducing damage. This can then result in the separation of osteochondral fragments, or it can avulse, like pull away the growth cartilage, and that can subsequently ossify. The lesion that we've circled here in red isn't a true osteochondrosis lesion because it doesn't affect the joint surface, but it will nevertheless result in a fragment as it traumatizes epiphyseal or metaphyseal bone. So I'm going to concentrate on the femropatellar, tarsicrural, and fetlock joints. I just wanted to go over some more site-specific areas of predilection in each of these joints. So starting with the femropatellar joint. So as we looked at before, the most common site is the lateral trochlear ridge, and this is followed by the distal end of the patella, the medial trochlear ridge, and the intertrochlear groove, which sits between both trochlear ridges. And in these radiographs, we've got a large lesion of the lateral trochlear ridge on the right and a large lesion of the medial trochlear ridge in the left. There is very thick cartilage in this area over the trochlear ridges, as we were looking at in this specimen, and it matures and becomes ossified later than in other joints. As mentioned before, the most prevalent site of osteochondrosis in this joint is the lateral trochlear ridge, and this is probably due to the shear forces caused by the overlying patella. In a recent study looking at foals at 6 months old, about 12% of thoroughbred foals were found to have lesions of the lateral trochlear ridge. We mentioned spontaneous regression or resolution of these lesions at various times in different joints. In a previous study, lesion appearance was thought to peak at about 6 months, and then by 8 months old, some would have resolved and others would become stable and not change. However, in a more recent study by Duncan et al., the window for this lesion resolution was found to be slightly longer. By 18 months old, 61% of lesions were found to resolve, 25% improved, and very few new lesions developed between 6 and 18 months. Lesions of the lateral trochlear ridge can vary significantly in severity, going from a very subtle depression in the bone surface as seen on the left to severe flattening with multiple and quite large-sized osteochondral fragmentation. More than one site in the same joint can also occur, as we've seen in this example a few times, and this will lead to a worse prognosis. Ultrasound is also a very useful tool for osteochondrosis, especially in the stifle. It provides more information about the cartilage surface, which you can't see on X-rays, and is even found to be more sensitive than X-rays. In the image on the left, you can see a subtle depression in the ridge of the lateral trochlear ridge with a little fragment next to it on the X-ray. And on the adjacent ultrasound scan, you can see the white line is the subchondral bone, and then we've got a hypoechoic or thick cartilage layer overlying that. There's a defect in the subchondral bone with the fragment sitting in the cartilage in front of it. So it does highlight them very nicely. Early detection of OC lesions has also been investigated by a team in Canada who used ultrasound to assess the lateral trochlear ridges of foals from 27 to 166 days old. They were able to assess the change in cartilage thickness, the ossification fronts, where the cartilage is becoming bone, and the blood supply as well. And they found that this all significantly decreased as the foal matured, which is normal. Subclinical osteochondrosis lesions, characterized by these dark, hypoechoic, semicircular lesions, were seen in the ossification front where the cartilage is being ossified. And they found that ultrasound provided a useful tool for early diagnosis of these subclinical lesions. So occasionally, if there are no localizing clinical signs for OC, nuclear scintigraphy can help us identify actively remodeling lesions It's not usually the main first-line approach for younger animals, but can be quite helpful with older animals with poor performance where you've got no localizing clinical signs or mild localizing clinical signs. So in this case, on the left, you can see a lateral projection of the left stifle, and you can see the arrows pointing to a focal, moderately increased radiopharmaceutical uptake area or a hotspot, which corresponds to this depression on the X-ray and the lateral trochlear ridge. So it can be useful occasionally. And this is just a nice ultrasound video of this same lesion, giving us some really nice detail about the size of the defect. You can look further around into the intertrochlear groove. You can see the extent in multiple directions of the defect. At the top of the ultrasound image, we've got the distal aspect of the patella and then the lateral trochlear ridge coming down. So moving on to predilection sites in the fetlock. When a recent study looked into common sites in both the front and hind limb fetlocks, it found that hind fetlocks were more commonly affected with a dorsal defect of the third metatarsal bone. This was the most common finding, followed by dorsal fragments. The OCF in this slide describes osteochondral fragmentation, so fragments. Whereas the dorsal fragments were found in a lower number in the fore fetlock. These figures were seen in thoroughbreds at 6 months old. By 18 months old, in the plantar aspect of the hind fetlocks, by 18 months old, fragments in the plantar aspect of the hind fetlocks and the dorsal defects on the third metacarpal bone were increased by 18 months old. So there was interesting data from this paper suggesting that a large number of fetlock osteochondral fragments appeared between 6 and 18 months old. 41% of dorsal fragments at 18 months old were new lesions. 46% of plantar fragments at 18 months old were new lesions as well. They also found that the dorsal fragmentation that was already present at 6 months had an equal chance of disappearing or improving compared to not changing by 18 months. There was significantly more new dorsal fragmentation at 18 months than those that had disappeared. So overall, there's a good chance of new lesions at 18 months compared to 6 months in the fetlock, and a low chance of them disappearing from 6 months to 18 months. When considering specifically plantar fragmentation in the hind fetlock, there was almost the same chance of lesions seen at 6 months disappearing, not changing, or deteriorating. And nearly half of these lesions seen at 18 months were new. So it's likely that joints without lesions seen on x-rays at 6 months could have initial sites of fragmentation or avulsion, which were not radiographically detectable. Now moving on to the tartar joint. The distal intermediate ridge of the tibia is the primary location, as you can see in the right radiograph at the top red circle, followed by the lateral trochlear ridge of the talus, which is here, and the medial malleolus of the tibia. Thoroughbreds were more likely, however, to have juvenile bone remodeling of the distal intertarsal joints and tarsometatarsal joints than osteochondrosis of the distal intermediate ridge of the tibia or lateral trochlear ridge of the talus. So really interesting that they are more likely to have the distal tarsal joints affected. Young thoroughbreds are more likely affected by juvenile osteoarthritis and tarsal bone collapse as well. So a link between osteochondrosis and osteoarthritis has been found in Icelandic horses by the same group that was studying the vascular supply. Icelandic horses are predisposed to distal tarsal joint osteoarthritis. And this research group in Oslo found a high incidence of distal tarsal osteochondrosis in foals and feel that the spectrum of changes of these two disease processes are highly similar. So they'll conduct more research to look into whether osteochondrosis can lead to osteoarthritis in the distal tarsal joints. When looking specifically at dirt lesions, 60% of those seen at 6 months remain stable, which supports the threshold age for no return between 5 and 8 months. So overall, from this data, lesions that remain in an animal after about 12 months are more likely to be permanent. So what other factors affect osteochondrosis? It's a multifactorial disease, including factors such as genetics, nutrition, and exercise. And it must be remembered that osteochondrosis is a multifactorial disease. It's not one component that's solely responsible. Only a proportion of osteochondrosis in thoroughbreds is found to be heritable, with the effect or the environmental effect of the mare and farm having an effect. When heritability has been assessed, even when taking into consideration very high error margins, the heritability estimates were significant at the Stifle, Hock, and Fetlock. The highest heritability was found at the lateral trochlear ridge, followed by anywhere in the stifle, the dorsal proximal P1, and the distal intermediate ridge of the tibia. So the environmental effects of the mare and farm may suggest that breeding and farm management practices such as feeding or other factors such as the parity or age of mares may be related to the likelihood of osteochondrosis and could potentially be used to alter the prevalence of osteochondrosis lesions in the thoroughbred. There would be potential significant benefits for the breeding industry if these practices could be identified. Further investigation of the relationship between the permanent environment attributable to the mare, including management regimes, diets during gestation, and the likelihood of osteochondrosis in the thoroughbred may provide some useful information. There are two groups of environmental factors that have been found to play a role in equine osteochondrosis, and this includes biomechanical loading and nutrition. Biomechanical loading of young joints is mainly determined by the exercise regime of foals or yearlings and includes the roughness of terrain and their conformation. We discussed the effects of biomechanical loading earlier and the influence it has on the well-defined and consistent predilection sites, such as the lateral trochlear ridge of the femur. After birth, the foal obviously undergoes dramatic biomechanical changes in loading, which are likely an important trigger for initiating these lesions. And this is supported by the fact that no osteochondral lesions were detected in fetuses in one study. Biomechanical forces acting on the cartilage canals that house the blood supply to the growth cartilage. When this area is particularly vulnerable, if these are damaged, these can induce osteochondrosis lesions. But yet again, biomechanical loading is only one component which influences these lesions. So there are many practical management recommendations from studies investigating the effects of housing and exercise. These management recommendations include keeping horses at pasture. Those that were housed exclusively at pasture until 1 year old did better than horses housed in stables or a mixture of at pasture and in stables. Those that were kept on strict box rest resulted in as many lesions as those that were turned out and galloped. And lesions in box rested foals were more severe, so box rest should be discouraged. Poor radiographic scores were also associated with mixed housing of in at night and out during the day, and it was also seen with rough terrain, so terrain with lots of stones or holes. This disease is also associated with irregular exercise, so periods of no turnout or turnout limited to 1 to 3 days a week. It's also been associated with large group sizes, so over 3 brood mares, and a large pasture size as well, so over 1 hectare before they're 2 weeks old, or over 6 hectares before they're 2 months old. And one recommendation is to achieve stability of lesions is to confine, if the foal is found to have a lesion, to confine the foal to a convalescence paddock of approximately 10 by 17 metres for 60 to 90 days whilst you monitor their progress. Nutritional factors have been extensively studied as possible causes for osteochondrosis. Substantial evidence supports a high growth rate within certain periods of time, most likely coincides with the various windows of ossification of the growth cartilage in these specific joints. Insulin and insulin-like growth factors can directly affect the endochondral ossification, changing the behaviour of chondrocytes. They can stimulate survival and suppress apoptosis. And insulin can also cause a rapid removal of thyroid hormones from the blood, basically producing a transient hypothyroidism. These thyroid hormones, T3 and T4, are involved in chondrocyte differentiation and growth cartilage blood supply before it's ossified. And a disturbance in this can retard growth cartilage blood supply, which we discussed earlier is directly linked to failure of endochondral ossification. This effect was seen more in weanlings than in yearlings, and it suggests a specific time window. With nutrition, imbalances and trace elements can also have an effect, especially seen with copper. And this can be affected by a mechanism acting via the enzyme lysyl oxidase, which is a copper-dependent enzyme that's important for the formation of collagen crosslinks. Zinc and cadmium can also cause a relative copper deficiency due to being copper antagonists. Calcium-phosphorus ratios are important for bone metabolism. High phosphorus has been found to induce a secondary hyperparathyroidism, which can lead to osteoporosis, a weakening of the bone. So moving on to thinking about treatments. Ideally, conservative treatment would be great if you can manage that, and if you're dealing with OC that's of a low enough grade to respond to that. So conservative treatment would include rest, controlled exercise, as we discussed, systemic NSAIDs, so phenylbutazone, intra-articular medications can be used. But really, it's only advised in very young animals with a good capacity for resolution of these lesions. We've discussed confinement to a convalescence paddock to try and help resolve these lesions. And small lesions that are less than 2 centimetres long or 5 millimetres deep without radiographic fragmentation. In the fetlock, mild flattening of the dorsal sagittal ridge with no fragments, you'd likely go along the conservative management route. Otherwise, the treatment option would be surgical, arthroscopy. So arthroscopy really allows examination of the entire joint to assess for other problems. It allows assessment of the cartilage surface, detection of loose flaps, hidden cysts, loose fragments, or any loose cartilage flaps. There have been some literature about using polydioxanone pins to fix large cartilage flaps, but as far as I'm aware, it's not widely used in the UK. So when thinking about the lateral trochlear ridge of the femur, as we said, if the lesions are very small with no fragments, conservative treatment is possible. But if after 12 months there is no resolution of the lesion and the clinical signs are still obvious, arthroscopy and debridement would be the best course of action. After arthroscopy, the outcome is 78% return to intended use for the grade 1 smaller lesions, grade 2, 63%, and grade 3, as they get larger with increased fragmentation, the return to intended use decreases. So the larger the lesions, the lower the success rate. There's also a significantly higher success rate seen if the horse is operated on before it's 3 years old. In dirt lesions in the hock, or the tartar joint, surgery is really recommended for all horses with clinical signs and an intended athletic career. After arthroscopy, 75.5% raced successfully or performed the intended use. And we have variable return to use for the differently sized lesions, but they don't necessarily agree with the size of the lesion. There was a significantly poorer outcome with articular cartilage degeneration, and the effusion of the tartar joint should resolve in 89% of cases. When looking at the dorsal aspect of the third metacarpal or metatarsal bone, again, we have our different grades going from very minor to more severe osteochondrosis. With type 1, the conservative option is available unless the clinical signs are more severe. And the prognosis is favourable. Type 2 and 3, surgical debridement is recommended, and the prognosis is less favourable if this is delayed. And again, if there are other signs of articular cartilage erosion or wear lines, there's a less favourable prognosis. If the lesion extends from the sagittal ridge, medially or laterally onto the condyles, there's also a less favourable prognosis. And when thinking about the dorsal aspect of the proximal phalanx, these fragments are often removed to prevent secondary osteoarthritis or for sale purposes. Now I'm moving on to a completely different area, the neck. We've talked a lot about the very common places for osteochondrosis, and I wanted to touch on the neck because it can also affect, osteochondrosis can affect any articular surface. And there's two joints on either side of the cervical vertebrae that communicate between each vertebral body. This radiograph shows very large osteochondral fragments at the caudal aspect of two articular process joints, and it's associated with the back of the joints. It's quite a complex anatomical area, the neck, and X-rays still provide quite a lot of superimposition of structures, so it's quite hard to see fine detail in neck X-rays. CT, computer tomography, provides this 3D image, and it aids in the interpretation of us seeing these smaller lesions, ones that you might not be able to see on radiographs, such as this small lesion in the top right image, which is a small osteochondral lesion in the articular surface. So CT of the neck is becoming increasingly used to diagnose lesions within the neck. So that's all I have today. So any questions would be very welcome.
Rhiannon, thank you very much for a wonderful lecture. I'm here with a number of the Beaufort Cottage Educational Trust trustees, and we're also joined by Duncan Moir from Baker and McVeigh. So we're going to start off with a few questions and comments from Duncan.
Rhiannon, thank you so much. It was brilliant, and I think we all agree in the room it's a very broad and complex caseload and topic, because it involves so many variables that so many of us have been trying to define and master for many years, and certainly talking as myself have failed miserably. But I think one of the things that I was interested to touch on what you were saying was with regard to the vascularity. And do you have any theories as to why some OCDs heal so quickly, whilst others, as you've touched on, at, for instance, an age of 18 months, are then pretty much consistent for the horse's life?
I think so. As we've said, the blood supply is housed in these cartilage canals, so I think it's difficult for it to form a collateral sort of anastomose with other vessels. So if a site is injured, then there's rarely the blood supply there to feed the cartilage. So I'd imagine it depends on the number of vessels that are injured in a certain site as to whether that site has a completely loss of blood supply or whether there is still some retention of blood supply, which allows a secondary kind of repair process. So I would imagine it would be the extent of vascular damage in that area.
So
but I think there is
sorry, go on.
I think there is still quite a lot of research to be done in that area to really definitively work out why.
So could, as a group of practitioners, we be doing anything more to diagnose and utilize management procedures at a very early stage of diagnosis, for instance?
Well, I was showing that research study with diagnosing subclinical OC lesions very early using ultrasound, but how practical this is. It obviously means handling the foal, sedating the foal, preparing the foal, imaging the foal, and whether you're going to use the correct management strategies anyway. It's hard to determine whether it's worth seeing those subclinical lesions, which may resolve anyway. So I think that would be a further area of interesting research to see how many of these lesions develop into clinical lesions and how many progress anyway, depending on the different management regimes. So that could be one way for a research purpose to look at the subclinical lesions.
I think I'm going to jump in and just comment. I think that paper is a really good start, isn't it? And it was done in a field setting. I think you're talking about Dr. Lafferty's work that was done in Ireland, aren't you? So it's a starting point on which to build into a potentially useful management technique. I guess early diagnosis is the key to managing so many conditions, isn't it?
Yeah, absolutely. And an easy way to monitor them will be very, very useful as well, if it can be done on site and practically.
Which brings me on to a sort of my next question or topic of interest, and that's the genetic predisposition of OCDs, and certainly in thoroughbreds. I think there was a study in 2007 done on more warm bloods, showing that there were some OCDs related to some genetic markers and others related to others, and it was exceptionally hard to actually create any basis of predicting which breeding stock or which individuals would be developing certain problems. Do you foresee that area maturing and becoming more definitive as the years go on, or will it be forever something that is subjective and confusing?
I'm probably not the best person to answer a question about genetics, but I can agree that it's a massively multifactorial disease. So for further research, I think it would be very difficult to pinpoint the heritability aspect solely as a defining factor.
Thank you. I think probably my last question, and I think a number of us in this room have experienced this over many years, but we in the thoroughbred industry particularly are subject to commercial pressures of horses being essentially saleable items at an early stage in their career. And certainly I've done some work on nutrition and growth curves and the effect of that on OCD rates in young stock, but also the effect on future soundness and racing. As an industry, are we putting our young horses under too much pressure to be big and fat and muscular too soon?
I think you're probably better placed to answer that, Duncan. It's obviously
an interesting point. Yeah, it's an interesting point, Duncan, and actually it ties in very nicely with one of the topics that we talked about earlier in relation to angular limb deformities or deviations. So I don't know if Matt wants to touch on that, but one of the main conclusions from the group was that, managing weight and has allowing foals to grow too quickly has all sorts of adverse effects. You want to comment, Matt, or perhaps Nick?
Hi, Rhiannon. That's a lovely talk. Thank you. I would agree with Duncan. I think it is an important point to consider. I think I'm in a similar position to you, where at my stage I'm probably more focused on the individual than the breed as a whole. But for sure, it's an important question raised. But as I mentioned, I think in the meantime we have to treat the individual, and I think there's overwhelming evidence to support removing these OCD lesions in order to protect them athletically and further their careers.
And just one point, I think that in rearing thoroughbreds now, we are so much more conscious of weight again than we used to do. Almost all of the well-run studs now would be monitoring weight and growth at the withers very carefully and making sure that the weight gains conform to the growth statistics that are generally considered to be desirable. And I think that's made a huge difference to the incidence of acquired osteochondrosis in the groups that I look after. Certainly overweight is not the way to go. Yeah.
So there's already positive steps being taken.
Okay, I'm going to hand over to Jack Day now, because I think he's got some other issues he wanted to comment on.
Okay.
Well, no, thank you very much for your talk. It was fascinating. Thank you. I'm not sure as it's actually necessarily that different, but it was just a point that probably almost ties back into some of the similar issues, that given that we quite often find these things unilaterally as well as bilaterally, and that there has been some fairly moderate work done on the sort of the asymmetry of horses as a breed, how much do you think that we could really say that we're still trying to look at OCD as a single problem, as opposed to maybe something that is far more multifactorial, and we're just seeing the outcome of 5 or 6 or 10 or 12 or however many different things going on, and that we're if you like, the proverbial drunk looking under the lamppost for the car keys because these are where we can find? Or do you think that we're really beginning to build up a picture here that's going to tell us something further down the line?
I think the research that's being produced at the moment is absolutely fascinating, and I think it's really giving us an insight into exactly why it's occurring, changing our thought process to think about the vascular supply of growth cartilage, as we would normally think of it as an avascular process, and that is the root of most of these osteochondral problems, is fascinating. And I think that the anatomical location bilaterally would support this, that if there's similar biomechanical forces, there's similar nutrition, there's similar biomechanical forces happening in those locations bilaterally, supports all the factors that we've been considering so far, if that answers your question.
Quite probably, yes. Yeah.
Rhiannon, thank you very much for an excellent talk. It's Fred here. Just 2 thoughts or observations. I think there's a lot of work, as we all know, going on into the genomics and epigenetics of around OCD. And I think the next few years are going to be fascinating to see what comes out of that, as a lot of that is being related directly also to or correlated with observations in rearing, in management, and in athletic performance, and the development of the young individual. At the same time, we those of us who run around the sales and have done so for many years, still have got this wonderful phenomenon of X-rays being cosmetically improved by removal of chips, and many of us would probably argue that many of these chips could very well have stayed inside in the animal and do not necessarily need to be removed. And so, there is no simple solution or answer to it. It is at times a bit fashion issue as well. I think we're probably seeing fewer chips removed today than maybe 10, 15 years ago. We've got a surgeon in the room who loves removing chips and has just told us every chip should come out. We've also seen it in other breeds, in the warm blood breeds, where for many years every chip has come out of every prospective young stallion in Hanover or in the Netherlands and so on. And many have stopped doing that now, realizing these animals can perform perfectly well with a chip in there. So are we still advocating that every chip should come out when we detect it, just because for economic reasons, or are we doing this really for the welfare and the best to maximize the athletic potential of the horse?
Well, that's a great question, and I'm certainly not going to give a definitive answer one way or the other.
I think
it's very joint specific, and I can see a definite reason for removing them if they're causing concurrent pathology in the joint, if they're causing concurrent cartilage degradation, wear lines, etc. So I'd very much say that there's a good reason if they're causing concurrent joint pathology.
So the answer really lies, I guess, as Matt already alluded to judge each individual on a case-by-case basis. What might benefit one individual would be determined by the additional findings that radiography and your other imaging techniques can shed on the whole situation. Is that a reasonable conclusion? I'm, I think, going to draw things to a close. All I would like to finish off by doing is to thank you once again, Rhiannon, for a beautifully illustrated presentation and certainly giving us some interesting, thought-provoking ideas to discuss. Thank you very much.
Thank you.